Hi, my name is Anisa Suraya, and I'd like to give a quick talk on acute alcohol withdrawal and management. I will begin with a case study of a 43-year-old man who was admitted to hospital for acute cholecystitis. He had a cholecystectomy, which went smoothly. However, 2 days after his operation, he develops confusion and agitation. He had vivid visual hallucinations of small people walking around the foot of his bed. He also had delusions that the nurses on the ward are not real nurses. He had extreme mood changes and would switch sometimes from extreme fear to laughing hysterically in the ward. On examination, he had a high temperature, he was sweating, his hands were shaking, and he was tachycardic. The tricky thing about this case study is that there's not really anything specific that's pointing towards alcohol withdrawal. If you were a doctor and you were asked to see this patient, which parts of the history would you be looking at to look for signs that this might be an alcohol withdrawal? If you already know that the patient is an alcoholic, then you may be more likely to think that this is an acute alcohol withdrawal. You may also look at the social history and see if there's any history of alcohol dependency, if there's also a history of drugs abuse. In the past medical history, you can look for physical complications of chronic alcohol such as liver cirrhosis, esophageal varices, peripheral neuropathy, or any acute admissions to hospital for acute pancreatitis secondary to alcohol, and the list goes on. You can also screen for risk factors of alcohol abuse such as a background depression, and just to eliminate that this is an acute cause of any other causes of delirium, you can also screen risk factors of delirium such as anticholinergics or background dementia. On physical examination, you can look for signs of chronic alcohol abuse such as gynecomastia or spider nevi, etc. Look for macrocytic anemia, which is a sign of B12 deficiency in the blood test. If this was acute alcohol withdrawal, you'll probably see a raised AST and a raised ALT, and also a raised gamma GT. The ratio of AST to ALT will be 2 to 1 in alcoholic. You also see a raised urea secondary to dehydration. You may want to perform additional tests to rule out other causes of delirium and to rule out other comorbidities. So you can do a urine drug screen to rule out other drugs of abuse, do a urine dipstick to rule out a urinary tract infection. You can do a blood glucose to check for hypoglycemia, look at electrolytes and blood tests to check for any electrolytes abnormalities which may be worsening the confusion. You can take blood cultures, urine cultures, etc. if sepsis is suspected as well. Also remember that these things can coexist with acute alcohol withdrawal. Now I'll go on to talk about the symptoms of acute alcohol withdrawal. Mild alcohol withdrawal is very common and happens in a lot of people just as the alcohol levels drop in the blood. It can cause headaches, nausea, vomiting, tremor, sweating, and some sleep disturbance as well. It can take a few weeks for the sleep pattern to return back to normal in mild alcohol withdrawal. Mild alcohol withdrawal is self-limiting and tends to resolve by itself without requiring any treatment. However, if someone is dependent on alcohol, they are at increased risk of experiencing severe acute alcohol withdrawal syndrome. The symptoms of severe alcohol withdrawal are seizures, delirium tremens, which is a medical emergency necessitating the admission to hospital, and it can also be fatal. Now for the rest of the tutorial, I'm going to talk about delirium tremens, which is a medical emergency and can result in death if not treated urgently. Alcohol is a CNS depressant. It stimulates the GABA inhibitory system to reduce brain excitability. However, when dependent drinkers stop drinking, this causes the brain to become hyperexcitable, and that's what leads to the symptoms of delirium tremens. The onset of delirium tremens is typically 48 hours after the last drink, but typically as well, in a dependent user, gross tremor can begin as early as 6 hours after the last drink. After 12 hours from the last drink, dependent users can start having hallucinations such as Lilliputian, which is visual hallucinations of small people, or formication, which is the sensation that there are small insects crawling on your skin. Typically, after 24 hours, the neural pathways in the brain are hyperexcitable, and this leads to seizures. Other symptoms include confusion, affective changes, switching from fear and hilarity, autonomic disturbances such as fever, sweating, and tachycardia. Patients also have delusions, such as the ones seen in the case study, and the symptoms tend to be worse at night. The mortality rate of delirium tremens is 5%, but it can rise to as high as 30% if there are complications such as sepsis. This is why it's also important to screen for other comorbidities and other causes of delirium. Patients with alcohol dependency tend to be deficient in vitamins and vitamin B12 particularly. Therefore, the management of alcohol withdrawal also includes parenteral thiamine and other vitamins. It also includes fluids and electrolytes to prevent fatal dehydration and correct any electrolyte abnormalities which may be worsening the confusion. A reducing benzodiazepines regime is central to the management of acute alcohol withdrawal in severe cases. Long-acting benzodiazepines are used, such as chlordiazepoxide, 20 to 30 milligrams up to 4 times a day. The aim is to reduce the dose every 2 days and to stop benzodiazepines use over 7 days to prevent any dependency. Lastly, in spite of the psychotic symptoms seen in severe alcohol withdrawal, you must not use antipsychotics as it lowers the seizure threshold and can precipitate withdrawal seizures further. Thank you for listening, and these are my references.